one of the first things is the taper is much different than on any of the other forms. Ideal is somewhere between 10 and 20 degrees, so it's really flared. And the only reason you even want to be in that zone is it just kind of helps hold your temporary on. And we'll talk about attaching temporaries to these later. But it is nice to have some definition, kind of a lock and key effect. But keep in mind with your final restoration, you're bonding it anyway. So we really don't, we're not relying on resistance and retention form at all. So let's start with, with taper or flare. Kind of see what we have. I'll try to get, I don't know whether, I've got my lamp turned way down. Can you see that okay? So we're just looking at overall taper flare. This one seems to, this is just a student's preparation. It's just one I grabbed. I look at the mesial box form. It seems to be nice and tapered. I look at the distal, same. Could it be flared even more? Yeah, probably, but is it okay? Yeah, it is. So looking at the isthmus, looking at the shoulder, looking at the boxes, they all have a taper that I would say is within that 10 to 20 degrees.
Hey,
yes?
Your light is so bright that it's blurring out.
So even with it turned way down, I've got it turned,
Way down.
I've got my light all the way off here. Is that still?
Yeah, it's like walking 2,000.
If you go back and forth, like you take your light off of it every once in a while, we can see what
That'll
we're
work.
talking about.
Yeah, I guess that is a little, I've got it, okay, I've got it all the way down. Can you see it or is that too bright? Let me get it. I may have to just do this without light. Let's see.
That works.
Okay, and I don't have any light on it at all, so I'm going to go ahead and just turn my lamp off. So, can you see those boxes? They're tapered. They have a little bit of flare to them. They're probably closer to 10 degrees than 20, but they're okay. Keep in mind your isthmus and your shoulder should have such short buccal and lingual, or hardly even an axial wall. You know, you're talking about maybe a half to 1 millimeter height. So we just don't want any undercuts or anything like that. So this one I'm going to, and I don't have my pen, let me grab something to write with. Got everything to come to write with.
Better if I get this.
Okay, so I am going to give this one full credit on the taper. That's a gimme. Just don't create it. Don't make it too parallel like you would for any other typical casting or other preparation. Okay. Now, non-functional cusp, cabo surface, ceramic angle. What does this refer to? So let's go to the non-functional cusp. So the buccal cusps. And it is the ceramic angle at the cabo surface. So what we're looking at is, if I can get the focus on there, we're looking at the exit angle of your occlusal reduction. And we're asking ourselves the question, okay, is this so steep that it will create a really obtuse exit angle, which is better than acute, right, for your ceramic? What's the problem with leaving this kind of steep right here? Any ideas, any thoughts?
Is it more easy to fracture?
Yeah, so then, you know, while you're in the temporary phase or until you get your final restoration bonded, that enamel is a little bit precarious and can chip off. So you don't want to make it too steep and make your ceramic exit angle too obtuse. So you look in your mind's eye and you say, well, what angle is that? I'll try to maybe put this on it. About that angle, something like that. And it's a little bit steeper, so it's going to be on the obtuse side. which is better than acute, but it's not exactly ideal. So if the occlusal reduction on the buccal cusp, the non-functional cusp, would have been just flattened slightly, just slightly, that would be more ideal. Does that make sense?
On the non-functional cusp?
Right, on the non-functional cusp. So it's, and again, if you look at the grading here, it's only a 1 point loss by being slightly obtuse on the ceramic angle, right? So it's not a big error, and it's very, very slight. You know, ideal is so that both enamel and your ceramic are going to be at 90 degrees, right? If you flatten out the non-functional cusp reduction too much, then what happens is your ceramic angle gets more acute, okay? And that would go the other direction, and you notice you lose points quicker that way. Does that make sense? So now we're going to go to both the mesial and distal box forms. So the mesial is on the left, the distal is on the right, and there's three criteria that we're looking at. One is axial depth, then the level of the gingival floor, and then the uniformity. Is it uniformly 1.3 deep axially all the way along the box? So let's look at the mesial. And I would say it's quite uniform. It's a little bit on the shallow side, just slightly on the shallow side. The distal is fine. The distal is a little bit better in terms of depth. So I would say on depth, mesial slightly under, just barely, and distal pretty doggone close. So mesial box form is going to be a little on the shallow, and distal is going to be right on. Let's see where we at here, right there, ideal. Okay, everybody good with that? Then on the uniformity, let's skip down to uniformity because it's easy to do those two together. Let's see here, let me see if I can get that at your camera. I would say that they're both quite uniform. Would you agree with me there? The distal, you could nitpick and say it's a little deeper toward the lingual, but boy, not much. That's pretty close. So we're going to say uniformity is good on both. That's full credit. And now level above the gingival floor. So this we have to kind of look at from the side. And we want to be 0.5 supragingival. You may not be able to see it very well there. But I can. And this is in the sweet spot on both of them. Okay, so good level in terms of being supragingival. 0.5 to 0.75 supragingival. The isthmus form. Okay, we ready to move on? So with the isthmus, all we're really looking at, I mean, you don't even have to have one of these, but it's part of the criteria for the ideal preparation. The isthmus form, we want you to be at least 0.5 to 1 pulpal to the occlusal reduction. Many of you, after you finished with your occlusal reduction, had to go back and refine your isthmus again. You had to add it because you obliterated it by your occlusal reduction. That's fine. Just go back and drop your isthmus to be 0.5 to 1 beyond the level of your occlusal reduction. Is that clear? Does that make sense? So we want to see a little step down in the isthmus. And this one's right on. It's barely a half, I would say. If you wanted to really get down, get dirty, you could put your probe in there and kind of check. But visually, it looks like it's 0.5 to 1 beyond. So that's the first criteria for the isthmus, right? Right there. So that's full credit. And then uniformity. How uniform, how smooth? It's a little bit irregular. It's pretty darn good. I would take it in a heartbeat. Clinically, it's got a little up and down, so I'm going to do just slightly off on uniformity, okay, because we're grading to ideal. Let's go down to the functional cusp shoulder now. So 3 criteria: axial depth, uniformity, and then occlusogingival height. They're very similar to the box forms, only slightly different. So axial depth is the same. And we want to look at the depth going in. It's going to be 1.3, so it won't be as deep as this, but if I took a KR diamond, that's the way this would be assessed, is lay a KR diamond on that. And I can tell when I put this 1.5 against that, that's about 1.3. That's really, really close. Can you see that? It's slightly less than the 1.5. So depth-wise, right there, it looks pretty darn good. And it's uniform, and it is the right depth. It's 1.3, I would say, very close to that, all the way around. It's just less than this 1.5 in, and it is uniform. So those 2 categories, we're going to go 5 and 5, and now occlusogingival height, when you're all done with this, it's going to end up being in the middle third somewhere. Now what determines where that is placed occlusogingivally? What is it that determines the occlusogingival height of the shoulder? What? Yeah, you need to have adequate room for your restorative material. What else? What are we trying to do with that shoulder? We're trying to improve the exit angle to create adequate space for our restorative material, right? So it's not an acute angle. So that shoulder, once you've refined your occlusal clearance, then you simply drop that so it's slightly past that, just to change the angle. And if you do it that way, it will end up being somewhere in the middle third. That's kind of what, but don't let that be the guide. In other words, the guide is your functional cusp bevel and the clearance. Then you add your shoulder. And so you don't want to end up with a great big axial wall along here, right? We're not looking, it's not an axial wall. It should be very, very short, and that one is. See how the shoulder just emerges right basically near the base of that little knob. And that's what we're trying to do. So the occlusogingival height of this is good. So that's a good score as well. So now we're going to go up to the occlusal clearance. This is one that really should be done quite early. It certainly should be done early in the preparation sequence because everything else keys off of that. So let's close things together. And we're going to look first at the non-functional cusp. It's maybe a little bit over, but it's probably not excessive. So if I was to put blue in there, it fits everywhere and it wiggles a little bit, so it's okay. It's okay. But remember, it's just a little bit steep. This preparation would be a little better if that clearance was achieved by reducing this at just a slightly flatter angle, not so steep, okay? But we've already accounted for that steepness part in this second category right over here in the cavo-surface ceramic angle on the non-functional cusp, okay? So on the non-functional cusp, the clearance is ideal, 2 to 2.5. On the functional cusp, we're going to do a couple of things to assess that. One is we're going to simply look. We're going to try to insert blue through there. It may not blow all the way through, but it should fit pretty well with a little wiggling, and it does, from both the mesial and the distal. There, let me make sure the distal is going through also. And again, this is just one tool, and we're also going to look at it from one tool of many, so we're going to look at it from the back side. And it might actually be, you probably can't see that, I'm going to have to put a light on this. Can you see in there? Or I got the angle off? I probably won't be able to get light. I don't know, tell me what, because I can't look at the screen end. Can you see that, Brett?
Tip it a little
Now we
more.
can see the space.
Can you see that?
Tip it a little more.
Like this?
No, the other way. There.
Okay, can you see it?
Tip it a little bit more. There.
Okay. So I can hardly see it now, but it's slightly over-reduced at the distal. Just a teeny bit. But again, I'd much rather have it over than under, right? So I'm going to just put slightly over-reduced on the functional cusps. Just a little bit, because that gap's pretty big at the distal. We good? Everybody see that? One thing about it, we can kind of cheat, can't we, when we're grading it, because we can look from this side. We can't do that clinically. So you just have to give it your best shot based upon the tools that we have to measure. The first one is the blue stick. The second one is just looking like this, and the third one, probably more important because this also is applicable clinically. Let me get my light back off. And that is to just look at it with respect to the adjacent teeth. So I want to look at this. Can you see how this is maybe a little over reduced when I compare it to the height of this premolar? Just a little bit overdone right in there. Okay? Let's compare it going back to the molar. Kind of the same thing. It's more toward the distal. Let's see if I can get that up where you can see it. Okay? So there's three ways to do the functional cusp on this to kind of assess clearance. One is simply having the patient close and moving your measuring instrument in from the buccal as far as you can get it. That'll give you an idea. Two is looking from the lingual. Once you can't do that clinically. Three is comparing it with the adjacent unprepared teeth. And fourth, does it look right? Does it look like this preparation should look in terms of just, it has a certain shape to it, doesn't it? And it is just a little over-reduced on the lingual, just by a couple of different methods, and so slightly over-reduced on the lingual. So right there, okay? We good? And then blending and rounding, let's go down to that. Blending and rounding of all of the line angles, and you need to go over all of these very carefully. Let's get it in focus. And we're going to look at this angle that goes all the way along, but this is basically the occlusal, the buccal wall of the isthmus angle from here to here, and we're going to extend clear around to where this distal box transitions to the occlusal reduction and where the mesial box transitions. And we want to make sure that those are slightly rounded. And I've got to get my lamp on for a minute just so I can tell, and then I'll come back to the screen. So I am going to say that we could be a little bit more rounded. Let me get my lamp off so you can see it too, hopefully. Let's see if we can get that into focus. I don't know whether you can see it or not, but it's a little bit angular still, right at that transition and that transition out of the mesial box. Distal box, a little better, but this transition is also just a little bit, it could be rounded just slightly more. So there's three spots where it could be just a little bit more rounded. It's not bad, but it's not perfect. And so that would then be a 10. And why does that carry so many points? Because that's such a critical aspect of this preparation, okay? You have a question? So the question is, which angle are you looking at? And make sure that, in answer to that, make sure that the cabo surface is always close to 90. So that one we never round. But what I'm talking about is the transition between the buccal and lingual walls of the box as they emerge onto the occlusal reduction part. So it's that line angle. It's not the flaring, it's that line angle that's created. We want to make sure it's rounded. So it's the actual line angle that we're rounding, okay? And we want to make it pretty round. I mean, this is not softening. This is not getting rid of an acute sharp spot. This is putting a little bit of a roundness to it so that it doesn't create a stress point internally within the restorative material, okay? So really a pretty darn good preparation all the way around on this. We'd score perfect here. We're -1, -2, -3, -4, and then -5, so -9, so this would be a 91, okay? That makes sense, everybody good? Any questions on it? So another question, hang on. It's an eyeball, just looking how smooth. Are you talking about uniformity of pulpal depth right here? Yeah, so basically, at that depth, whatever it is the pulpal floor nice and uniform and smooth? So, or is it going up and down? Is it undulating? Does it have jagged areas in it? Or is it, smooth as glass? That's what we're looking for. We want it very smooth, shows us good handpiece control, good hand control. Quite honestly, at the end of the day, if it's, clinically, if it doesn't have sharp spots in it, you're gonna be okay. The more regular your preparations can be though, the labs seem to be able to do a better job of giving you a very nice, well-fit restoration. So uniformity does help. Exactly. The height is on the previous category. So on pulpal depth of the floor right there, that's how far beyond it is, how far it's reduced beyond the occlusal reduction. Exactly, and that's why we give you that range. Yeah, that's, we just want you to be a little bit lower, and in places that's going to be a taller wall, and in other places it's going to be a shorter wall. Yeah. So does everybody get that? On this category right here that the question focuses on, that pulpal depth, even though it may be just as smooth as glass on the pulpal floor, you may have done a wonderful job, which is what you're supposed to do. The actual point at which you measure the buccal or lingual wall of that isthmus is going to vary. There'll be places where it'll be a little taller and where it'll be a little shorter because your occlusal reduction is irregular. It will be within that ½ millimeter range though, if you've done it correctly, okay? Any other questions? So does that give you an idea kind of what we'll be doing next week then? And as you can see on this form, I haven't converted it to the faculty assisted student grading, but I will. The categories are the same, the scoring is the same, but that is basically the form. So, very good. All right.